All right. Thanks everyone for being here. A big thank you to all of our interpreters for being here and supporting us with this amazing presentation today. We're super excited to have everyone. A reminder that to support interpretation, we ask that you be mindful if you have questions and be mindful of your pace so they can capture all the amazing things that everyone has to say. As well as we request that if you do have a comment and come off unmute, that you say your name first so the interpreters can capture when we've transitioned from one person to the next. So with great honor, we would like to be able to introduce Jami and Gabriela from the National Center to do our presentation on using a harm reduction approach to support survivors who use substances, part 1. I will go ahead and hand it over to you both.
Good afternoon, everyone. My name is Jami Wilson. I am a training and technical assistance specialist with the National Center on Domestic Violence, Trauma, and Mental Health. And I'm going to share my screen here. Before we start, I will say there is a little construction going on in the background. If you hear that, my apologies. But as we get started, my role here as a training and technical assistance specialist is focusing on addressing not just substance use in relation to domestic violence survivors, but also human trafficking. And so I will turn it over to Gabriela.
Hey everyone, so glad to be here today with all of you. I'm Gabriela Zapata Alma, and I'm the Associate Director with the Center.
Thank you, Gabriela. And so this is just a little more information about the center and the work that we do. And today, our goal for the training is to discuss the intersection of substance use and domestic violence, and also examine what substance use coercion looks like among survivors of domestic violence, as well as define harm reduction and determine how harm reduction practices can be applied when supporting survivors. So before we start, if everyone could just go ahead and type in your name, title, and place of employment in the chat box. We're going to be using the chat box quite a bit today. That's where you'll enter your questions, as well as we're going to have a few discussion topics and questions throughout the training. So if you could go ahead and enter that so everyone can see who is joining. As a reminder, as we go through the training, if you have any questions that you don't feel comfortable asking yourself, feel free to send those questions directly to Brandy or Miranda, and they will ask those questions for you. Okay. All right. So let's begin with a discussion question, and I'll turn it over to Gabriela.
Thank you, Jami. So what would happen if we only provided services to people who agreed to leave an abusive relationship? What would happen to the survivors we work with? And feel free to answer in the chat. You're also welcome to unmute and share if you would like. many would not be able to access life-saving services. Yes. Mhm. Put them in a more dangerous situation. Yeah. Or taking away their freedom of choice. Yes. Yeah. And would survivors feel understood and welcomed, or would they feel judged? Yes. We're adding to the messages of stigma and shame around domestic violence. Yes. And so, and here, the barrier to entry would be even more restrictive and may feel less inclined to get help in the first place. Reaching out to get help is not easy, not an easy decision for someone to make. Absolutely. And so this would set up all kinds of barriers for folks. And so we want to invite everyone to really think about this question when it comes to substances, that when a survivor is using substances, really, it's like any other relationship that may carry some risk, right? And so the same things that would happen if we only provided services for people who are ready to and agreed to leave an abusive relationship, those very same things happen when we either pressure or expect survivors to be able to stop using substances in order to be able to access our incredibly important services. So those very same things in terms of the stigma and the shame, the danger that people face, right? And the lack of access. Amy, I'll hand it back to you. Yes. So thinking about the spectrum of substance use. So a lot of times we talk about substance use in our communities and our society as if it's just a yes or no, that some substances can be okay to use, but other substances are automatically dangerous, or somebody must have, really big problems if there's using those substances. And so a lot of times there's this false hierarchy of substances that many times has more to do with socioeconomic class, with race, with whatever substance we have access to, than how dangerous or not dangerous the substance itself is. So rather than thinking about this substance is dangerous and that substance isn't, or all substances are dangerous, instead really taking a broader look and understanding the spectrum of substance use, that relationships with substances exist along a spectrum. On one end, you see beneficial use that is somehow helpful for a person. And I'd love to invite folks to put in the chat any examples of beneficial use that you can think of. Yes. So from beneficial use, moving along the spectrum, we also see casual, or sometimes what's called recreational use. And so this is use that isn't really having any negative effects, right? That a person still has a lot of choice around their use, and it's not really causing any negative problems in a person's life. Now, the vast majority of people who use alcohol and other substances use them in a way that don't cause problems in their life and don't cause safety issues for people around them. Now, once we move past that center line, we start to see some problems or some risks come up related to substance use. And so here we're starting to see use that is starting to have some negative effects in a person's life or for their family or larger community. Now, a lot of people may experience a risk or a problem related to their use, and then they just naturally kind of change their relationship to substances in order to really decrease that risk. So, for example, somebody may, be running late to meet up with friends, and their friends have already eaten, and they go ahead and join their friends having a drink, and not realizing that they skipped this meal by accident, and now their tolerance is lower, and they're feeling the effects of the alcohol much more quickly, right? And let's say for them, they find that to be a really negative effect. Now, for many people who've had this experience, then it becomes a learning experience. And the next time they then remember, okay, I remember last time this happened, I felt really sick. So now I know, even though I have to make sure that I don't forget to eat, or even though my friends have eaten, I'm going to make sure to get something to eat, or I'm going to drink less, right? And so a lot of people may experience a problem related to use and then just kind of naturally self-correct as they learn from that. Now, once we get all the way to the far right side of the spectrum, that's when we start seeing continued use despite negative consequences. And a lot of times this is called chronic dependence, this is called chaotic use. Sometimes this is called a diagnosable substance use disorder. And the thing to know about this part on the spectrum is that the vast majority of people who use substances aren't on this point of the spectrum. But for those people who are, there's no rule that's going to change the fact that someone is experiencing substance use in this way. And there's no like punishment or taking away of something that's going to make it better for people. It actually makes it much, much worse and much, much more dangerous for people. And so when people are in this place of continued use despite those negative consequences, what people really need is our support and our non-judgment, right? And so thinking about that, if I'm trying to make a rule to change someone's behavior when they're in this place, then it's really setting somebody up for failure. And instead, what helps is meeting people where they are with acceptance, with compassion, and helping them to stay as safe as possible. Next.
Thank you, Gabriella. So here we have just some statistics related to substance use and domestic violence. And what we've seen, especially over the last few years with the pandemic, is high rates of domestic violence, especially among women accessing substance use disorder treatment. As much as 90% of women accessing substance use disorder treatment have reported experiencing domestic violence. And as much as 67% have experienced domestic violence in the last year. Victimization by an intimate partner also increases the risk for depression, PTSD, anxiety disorder, suicidality, as well as substance use. So you see some of the numbers here. For instance, someone experiencing domestic violence is 3 times more likely to also experience PTSD, major depressive disorder, and self-injury, and 6 times as likely to experience a substance use disorder. So as I mentioned earlier, we're going to talk today about substance use coercion. And substance use coercion is typically talked about when speaking about human trafficking. It is a very common form of coercion, but substance use coercion is actually very common among domestic violence survivors as well. So substance use coercion is coercive tactics specifically targeted toward a partner's use of substances as part of a broader pattern of abuse and control. So what does substance use coercion look like? Well, it could be a partner deliberately introducing their partner to substances, whether it's because they don't want to use alone or as another form of power and control. Interfering with their access to treatment, determining what types of treatment they are allowed to participate in or able to participate in. So for instance, they may be prevented from participating in an inpatient program as opposed to an outpatient medication assisted treatment program. Sabotaging recovery efforts and using stigma associated with substance use to discredit their partner and prevent them from the safety and support that they need. What effect does substance use coercion have on survivors? Well, we've seen how it can impact mental health, can also impact physical health and well-being. It increases isolation or feelings of isolation and entrapment. It creates barriers to economic stability. It can jeopardize custody of children or dependents. It undermines survivors' recovery, prevents that access to treatment, and increases risk of overdose. So say, for instance, the partner is forcing, the abusive partner is forcing the survivor to use opiates and benzodiazepines, so like Xanax, Valium, Klonopin. Both of those are respiratory depressants, and when used together, increases the risk of overdose. These are just more, this is just more information on substance use coercion and some statistics. These statistics came from calls to the National Domestic Violence Hotline, where a survey of over 3,000 callers was completed. And so we see here that during that survey, of the more than 3,000 callers, 43% had experienced some form of substance use coercion. 1 in 4, over 1 in 4, had used substances to reduce the pain of domestic violence. And 1 in 4 had been pressured or forced to use substances or made to use more than they wanted. So we see two different aspects of substance use here. So they mentioned substances being used to reduce the pain of domestic violence. So we have survivors that may have been introduced to a substance by their partner, but continue to use because it allows them to cope and survive throughout the day. And then you have the other aspect where they don't have control over what they use at all or how much they use, and they're being forced by their partner. I'm sorry, did I skip? Okay. And so I'll turn it back over to Gabriella.
Thanks, Jamie. So here on this slide, we see just the complexity of the control tactics of substance use coercion, how all the different things that Jamie mentioned when describing substance use coercion really come together to form this incredibly complex and impossible pattern of abuse that makes it so difficult for survivors and their children to establish safety and well-being. And something that really makes it that much more difficult is all the ways that stigma related to substance use is pervasive throughout all the systems that are meant to help survivors. And so thinking about the ways that substance use allegations in a courtroom are used to block survivors from being able to get an order of protection. Or, in talking with survivors, so often what I heard was how an unsafe partner had told them that if they ever tried to get any kind of help, nobody would help them because of their substance use. But of course, the words they used were much more demeaning and painful, right? And the part that is truly, truly unacceptable and tragic is how survivors have shared with us that when they did try to get help, when they did try to get safety from an abusive relationship, how many times they were turned away from domestic violence programs, from housing programs, how many times different resources that were meant to help them and their children in establishing safety told them that they weren't welcome. And so what they came to find out was that what that unsafe partner had been telling them, that no one would help them, that the service providers had proved that person to be right. And so we don't want any of our services to be proving an unsafe partner right. We want our services to be the total opposite of the power and the control that survivors face in the abusive relationships every day. And so anywhere where there is a place for stigma to come into our service, that is a place where our services can be used to harm survivors, right? And so a really important part of this work is going to be to eradicate stigma related to substance use. So when I was a housing provider, I can't tell you the number of times that an abusive partner would find out that someone was in our program and would leave me voicemails, would call me saying, oh, well, that person just uses substances. You need to kick that person out, right? Thinking that that would get somebody kicked out of our program. And then we know so often that when a survivor doesn't have access to safe housing, they don't really have many choices. And where they end up most often is back with an abusive partner, right? And so anywhere where an allegation of substance use, where something related to substance use can harm a survivor, that's a big danger for survivors, right? And so while we don't have control over what, and the different substance use coercion tactics that an abusive partner may use, we do have control over our own program policies and the steps that we take to eradicate stigma. Next.
All right. So this is just more information about how domestic violence affects mental health. So this comes from a separate call to the National Domestic Violence Hotline, a separate survey of callers. And among these 2,500 plus callers that responded to this survey, 89% had experienced at least one type of mental health coercion. And so an example of mental health coercion is kind of talking about what Gabriella mentioned with using stigma in court cases or calling programs and trying to get their partner exited and because of substance use or mental health diagnoses. Another example would be just their partner calling them or labeling them crazy. Everything that they do, everything that they feel, they're just being crazy, irrational. 3 in 4 people said that their partner deliberately did things to make them feel like they were losing their mind, that they were not what they were experiencing was not real, was just in their head or their mental health. And so that is another way that abusive partners can use mental health or substance use to exert that power and control over their partners. But just trying to make them believe that they are wrong, that what they're feeling and experiencing is wrong, and not really happening. This study also found that people of color, in particular Native Americans and Alaska Natives, were disproportionately impacted by substance use, coercion. And so that is another thing that we have to be aware of, is how substance use coercion impacts different populations, marginalized communities. And that's another thing to think about as we are serving survivors. Are they at a greater risk of being impacted by substance use coercion? And before we move forward, another way that abusive partners have used substance use coercion is not allowing survivors to engage in not just treatment, but other aspects of recovery, like mutual aid meetings. So that's like NA, AA, and also withholding transportation to treatment or any sort of support or resources that could further their recovery. And allow them to reach their goals in treatment.
Jamie, this is Brandy, and I wanted to let you know we do have a question in the chat, and this question is a pretty common one, actually. So thanks for asking, Claudia. So what about shelters that prohibit substance use on their grounds? Should they be allowing use?
Yeah, this is a very good question. And so I'll start by answering, and then I'll turn it over to Gabriella, because I'm sure Gabriella has something to add to this one too. So if someone is continuing to use substances while in shelter or transitional housing, it isn't, it's not necessarily a reason to exit that person from programming or to deny them entry into the program. So what we want to do in those spaces, or in those situations, is to, number one, I would say, is education. Educating the survivors on why it is unsafe to use on site, why we can't use on site. So, just talking about the fact that children or even other adults can get a hold of the substance or the accessories that they use to administer those substances. So first things first, education, yes. Secondly, you can look at ways to make, because survivors with substance use that are still actively using are probably going to be using while they're in shelter, but not necessarily on site. What you can do is have lock boxes set up like you would with medicines, and say, for instance, okay, we understand that you are using whatever the substance may be, but because we cannot have drug use on site, substance use on site, we're asking you to lock up these substances and anything that you use to administer them in this lockbox like you would a medication. That is one solution. You can also have sharps containers or disposal areas outside the shelter for safe and easier disposal. Education also includes connecting your survivors to harm reduction services in the community, and we'll talk much more about that coming up, but connecting them to those harm reduction services also provides them with more options for safer use while they are receiving services. So I'll turn it over to Gabriella.
Thank you, Jamie. So a program has to decide what policies work best and for the survivors whom they're supporting in their community. Now, what we would really advocate against, and actually would go against federal regulations, is if a program is screening people out because of substance use, or a program is telling people that they have to stop using and they must go to treatment, right? All of that goes against federal regulations around voluntary services and providing shelter services for people who have a need for shelter services. So we should be screening in based on need, not screening out based on anything having to do with substance use. And program exit shouldn't have anything to do with substance use either, right? So after that, kind of where and when the substance use happens, I would say there's a lot of different ways that programs approach these policies, but that the programs that have shared with us that they're having the greatest success are programs that are using a low barrier approach. So programs that are engaged in rule reduction and are really focused on very, very small amount of rules that relate directly to safety. And that when a survivor is struggling with keeping up with a rule, that's an opportunity to come together and figure out what are the options and how can we work together in order to support this survivor, right? And that it's not about, oh, you broke a rule, it's time for you to leave, right? That's not the tone of the conversation, but it's one around, this is the expectation, this is what we need, this is why it relates to safety, and let's come together to figure out what you need in order to be able to be within this expectation. Now, an expectation like no substance use ever doesn't make sense. It's just not reality. And programs that have expectations like no substance use is ever allowed, they actually tend to have the same amount of substance use. It's just that people can't talk about it. And when people can't talk about it, they can't safety plan around it, and they can't get resources around it, right? So it actually leads to a much more dangerous situation for everybody, and a much more kind of fearful environment for everybody. A sweet spot that a lot of programs have found is that survivors, there's no kind of policies around whether or not they use substances, but that they do have a policy that substance use can't happen on the premises of the shelter, which is what you're raising here. You know, is it okay for shelters to have this policy in place, or should they be allowing use? Now, what I would say to that is that many shelters have found that not having use on site, but not having other policies that kind of penalize survivors who are using in general actually works really well for them, because then they're able to maintain that environment on site while at the same time being able to work individually with survivors around safer use, around safety planning and where they are going to use, all of those kinds of things. And that survivors have shared that a policy that says that they can just never use ever is completely unrealistic, but that having support to figure out when and where they can use safely while still maintaining access to safe shelter, that's more workable, that's more realistic. Now, if there is a program that either is considering allowing use on site, or has funding that would allow having use on site, which I have worked in programs where the funding did allow having use on site, that really that is the best when it comes to safety planning, because it is hard to expect that people have a safe place to use when they're not allowed to use in the safety of their own home, right? That's pretty difficult. Any one of us would have a hard time to have a safe place if we weren't allowed to use in our own home, right? But that said, there's a lot of reasons why programs aren't able to really have that policy. And so instead of having that policy, at the very least, not screening people out and not exiting people because of substance use. So thank you so much for that question, and feel free to keep them coming. So thinking about domestic violence in the greater societal context. So domestic violence exists and is intertwined with violence on a structural level. And so that interpersonal violence and all of the traumatic effects of that abuse is linked into ongoing structural violence and the traumatic legacies of historical trauma. And so Jami mentioned earlier how part of substance use coercion is not only introducing somebody to substances, introducing them to a way of using that is causing problems in their life, but that on top of it will block them from getting any kind of help around that substance use. Well, on top of that, when we consider the histories and legacies around both historical as well as current day structural violence, it's also important to note, for example, that a person of color is much more likely to be criminalized because of substance use rather than have access to resources that will help them with substance use. And people of color are much more likely to even have access to treatment because they now have been charged with a felony and are mandated to treatment. And many times when people are mandated to treatment, they don't have a choice of provider, right? Versus white counterparts who are much more likely to have access to treatment through voluntary means rather than through being criminalized. So when we are thinking about substance use coercion and domestic violence and trauma on the personal level, we also have to think about all the different ways that power flows on that societal level and how that intersects with substance use coercion to create even more difficult situations that are full of all kinds of barriers. In addition to what I just mentioned, as well as LGBTQ people are much more likely to experience discrimination when they try to access substance use disorder treatment. And so here I am trying to access a resource around my healing related to trauma and substance use, and instead it becomes a site of more harm, right? And so we need to really think about how stigma around substance use and the harms around substance use coercion are really intertwined with that systemic oppression and structural violence, and how anywhere where there's stigma around substance use in our services, that's also a place for things like racism to enter our services. Because people of color are much more likely to experience scrutiny and to experience a punitive, judgmental approach in relation to their substance use, rather than an approach that is based in compassion and support. And I will pass it back to you, Jami.
Thank you. So now we have a poll question that we're going to answer in the chat box. And so this question, I just want to get a better idea. Do you work for an agency that favors a harm reduction approach to program policy and practices? A, yes. B, no, ours is a more abstinence-only approach because harm reduction can include abstinence. Or C, I'm not sure. I don't know much about harm reduction. Yes, no, I'm not sure. And I'm going to stop sharing just for a second because I do want to see. Okay. Okay, so we have a few responses so far. See a few A's, good. A C, okay. So we're going to talk a lot more about harm reduction today. So hopefully, once we get finished with our discussion, you'll have a better idea of what harm reduction approach is. Okay. All right. Just one. Okay, so let me go back to sharing my screen for you all. All right, so what is harm reduction? Harm reduction, in a nutshell, refers to policies, programs, and practices that aim to minimize the negative health, social, and legal impacts associated with drug use, drug policies, and drug laws. Harm reduction is grounded in justice and human rights. It focuses on positive change and on working with people without judgment, coercion, discrimination, or requiring that people stop using drugs as a precondition of support. Okay. In other words, meeting people where they're at. We use that a lot, but that is really what harm reduction is all about. Okay.
So these are the core harm reduction principles. And as I go through them, I'd love folks to reflect on how these align with your principles and values as an advocate. And feel free to put any kind of responses in the chat as you, are reflecting on this. So first, one of pragmatism. So rather than focusing on moralizing or kind of judgmental approaches, instead focusing on what works. What is actually going to help a person be as safe as possible? What is actually going to help a person to reduce the harms that they're experiencing, as well as be able to live the best life possible? Partnership. That everything we do is done in partnership with the person whose life it is. That at no point are we telling somebody what is best for them, but that people are experts on their own life. And really anything that we do needs to center them and their expertise of what's best for them and what's most possible for them. Appreciates nuances, understands that life is complex, that people have a lot going on, right? And that there are no simple answers to what people are facing, and really appreciates and can hold the complexity with people, really appreciates all that people are going through and all their priorities and their needs as they define them. Focuses on individual and community well-being, so that rather than focusing on just whether or not someone is or isn't using substances, instead focuses on overall well-being and overall quality of life for the person, as well as for the larger community. It's non-judgmental and non-coercive. So take substance use as just it is what it is, takes a matter-of-fact approach to substance use instead of being judgmental, and seeks to really work alongside people and offering support, and never trying to coerce or force people into anything. That it's participatory, that everything that we kind of design and do from a programmatic standpoint must involve the people who are impacted, that we must be centering the people whose lives are impacted in order to create any kind of programming or do things that work. And so here, what we often say is nothing about us without us. And so harm reduction at its core is about that, really centering that expertise of lived experience and focusing on what works. It's empowerment based, so that it's not about top-down approaches. It's not about, getting people to do certain things, that it's about building an environment where people have more decision-making power, where people's voices are centered and honored. Harm reduction takes a human rights and anti-oppression framework, that harm reduction understands the way that people experience the world differently based on their positionality and their access to power in the larger society. They also look at how different people, how the power on that greater scale really shapes a lot of the choices and resources that people have access to, and then focuses on equity as a core component of everything that we do. And then ultimately is reality-based, is looking at what is realistic. There has never been a society that is free of substances, and there are ways of using substances that are clearly more dangerous than other ways of using substances. And so in that way, focuses on the reality that is here and now, and how people can be as safe as possible, as healthy as possible, and as connected and empowered as possible in their own lives. Next. Jamie, is this me again? No? Okay.
Sorry, you guys, I couldn't unmute myself for some reason. So let me go back to share that screen for you all. And thank you, Gabriella. All right, so harm reduction services. So what do harm reduction services look like? There's a wide range of harm reduction practices. So one I've already mentioned is education. This could be safer drug use, overdose prevention, overdose education. Safer drug use can look like, so from my time as a substance use counselor, some of the things that we used to do was talk to our patients about using where there was naloxone or Narcan readily available, testing their drugs for fentanyl. Those are just a couple of examples of safer drug use. Needle or syringe exchange programs or syringe programs are another popular example. These programs not only provide new, clean materials for substance administration, but they also typically have a lot of education there, support staff that can connect substance users to treatment if they so wish. to enter treatment, as well as other health resources. There's medication assisted treatment. This could be a doctor or a clinic setting, where medications, typically, we talk about MAT when we're talking about opioid use. So they are typically the physicians or clinics that provide medications like methadone, Suboxone, Vivitrol. Housing, stable housing, just like with any other population that we're working with who is experiencing or has experienced violence, safe, stable housing is extremely important. I mentioned drug checking, fentanyl strips, and we'll talk a little bit more about this during our next session, but there's also new testing coming out, or drug checking coming out for a substance called xylazine, and we will talk more about that in our next session. Safer sex resources, health promotion services, peer-based services and supports. All of these are examples of harm reduction and providing holistic or wraparound services to survivors experiencing substance use. And it's also important that survivors are connected to advocates or resources where they can access public benefits, healthcare, and legal advocacy. So, and I'll turn it back over to you for this one, Gabriella. I do want to just do a time check. We're at 3:02.
Perfect. Yeah. Eastern.
Yes. Sorry about that. Yes.
No worries. I knew what you meant. But just in case any of our Mountain Time friends are like, what? So harm reduction has been associated with so many benefits. Harm reduction works. So from different harm reduction programs, it's been found that harm reduction helps to decrease fatal overdoses at a community level, decreases HIV and hepatitis C transmission, which we know that survivors are also at increased risk for being exposed to HIV and hepatitis C, increases engagement in health services, which we know that domestic violence impacts a person's health, also increases safe disposal of different kinds of materials that are used for using substances, as well as increased access to wound care, which we know can pose a lot of harms and dangers for people. And then what's amazing is that through harm reduction, people are actually much more likely to engage in treatment, in recovery, have stable housing, all these things that we want people to have access to, all are increased and improved through harm reduction. And it makes a lot of sense why. Because when people feel that, we're meeting them where they are, that they can trust us, that we care about them, that we're not there to control them or take away their choices, then that creates an environment of healing. That it creates an environment where people can actually access the resources that they'd like to access. And so we now see a lot of public health agencies adopting harm reduction. But something to keep in mind here is that harm reduction strategies work because they center people who use substances. because they're strategies that come from people who use substances. And so always centering the people whose lives it is in what we're doing. Next. Not letting you unmute again. Oh no. Well, we can't hear the construction on your end, so you can just stay unmuted.
Okay, sorry, you guys. Thank you for being so patient. All right, so now we're going to talk about dimensions of use, drug set setting. This gives us a better, it offers a framework to understand the individual's experience and pattern of substance use, and allows us to conceptualize that use, and identify ways that we can help someone to reflect and discuss their substance use in a non-judgmental way, and help identify risk and harm reduction strategies. Okay, and so substance use experiences, as we've discussed, is highly individual, and but it's influenced by three key factors: drug, set, setting. So the drug is the substance itself, the route of admission, amount used, and the chemical reaction on the person's brain. So think of it, the drug being the substance and those things directly related to using that substance. With set, we are thinking of the mindset of the person before and during use, their physical health, and their expectations of the substance use experience. Thinking of this, experiences of fear, guilt, anger, or shame associated with use, or not even associated with use, but just in general, can increase use, and also increase riskier patterns of use, or as Gabriella mentioned earlier when we were talking about the spectrum of use, that chaotic end of the use, the spectrum, it can increase that chaotic use behavior. And it can also lead to more distressing substance use experiences like overdose. The setting is the environmental factors. This includes social, cultural, and physical environmental factors. Whether the substance use has to be hidden, the time of day that the person is using, where they use. So going back to safe use places or locations, when people have those designated areas, they're less likely to engage in that riskier, like hiding that substance use and potentially creating a safety risk for others in a shelter setting when they have access to safe use areas. And so keeping this in mind, drug, set, setting, the substance, the mindset of the person, and the environmental factors, we're going to look at a specific scenario. And together, we are going to determine what the drug is, the set or mindset of the person using, and the setting. So let me just share that with you. Sorry, let me pull the scenario up for you. Okay. So in this scenario, we have Victoria. All right, so Victoria is a 47-year-old woman with a history of domestic violence and sexual assault. She drinks a case of beer and a pint of vodka every day, usually starting in the morning. She does not eat a regular meal every day, and her prescribed medications include an opioid pain medication for chronic back pain and a benzodiazepine for panic attacks. Victoria reports her current boyfriend is sweet, but that sometimes he gets out of hand when he's wasted, but it's nothing she can't handle. Victoria reports her main concern is an ex who continues to stalk her and recently attacked her as she was walking her dog near her home. She currently does not want any kind of legal intervention in addressing her ex's ongoing targeting of her, stating that she doesn't think police or judge will take her seriously because she's usually drinking when these events happen, and that she can't remember any of the details. I'm going to stop here. I just realize I'm reading fairly quickly, and I just want to make sure that our interpreters have a chance to catch up. I'm sorry about that. She shares feeling intense guilt, shame, anger, and fear. She also shared that sometimes she drives when she has been drinking. Victoria lives alone with her dog in a rural community where her closest friend lives an hour away and her significant other lives 2 hours away. Her significant other tends to visit about once a week and will stay at her home for 2 to 3 days at a time. When he is there, she tends to drink more hard liquor than usual because this is what he drinks, and he makes the drinks for both of them and encourages her to keep up with him. She isn't sure exactly how much she drinks on days when he's visiting. She usually ends up taking her prescribed benzodiazepine when he is there because she experiences more panic attacks when he stays over. She doesn't want to give him a reason to call her crazy again. Okay, so that is the end of this scenario with Victoria. Keeping this information in mind, I'll leave this up so we can refer to it. But the first question is, what's the drug? And feel free to respond in the chat. As well as out loud, just unmute yourself. What is the drug in this scenario?
Jamie, and this is Brandy. In the chat, we have folks listing alcohol, Xanax, alcohol, and meds. That's what we have so far.
Great, yes. So she drinks a case of beer and a pint of vodka every day. And so, although it does not say she's taking more pain medication or benzodiazepines as prescribed, she should not be drinking and using the benzodiazepine, so that would be a factor as well. Okay. All right. So thinking of this scenario, what about the mindset, Victoria's mindset? C1 response: depression, anxiety, hopelessness, isolation. Yes. Yeah. Okay. And setting, environmental. This is social, cultural, and physical environment. What are some of the things impacting her?
Jamie, this is Brandy again. And so for the set, we also had verbal DV abuse is causing her anxiety and then trauma. And for setting, we have rural. So I want to share that. I think we have folks sharing all the different parts. So we have another sharing piece for the second part, the setting, isolation, fear, and anxiety around our own safety within the relationship and within systems.
Yes, perfect. All right. Yes, and I see that someone brought up the stalking. Yes. By her ex, that's yes. So not only is she experiencing, well, I didn't even touch on this. Did anyone notice any elements of substance use coercion in this scenario? What was an example? What would you say is an example of substance use coercion? He makes the drinks for her. Yes. He wants her to keep up. Yes. Correct. Yes. Did anyone catch why she takes the benzodiazepines when he's around? Scroll back down. Yeah. He's called her crazy before, and we talked about that as a form of mental health, using mental health as the stigma around mental health as another way of exerting that power and control over their partner. Yeah. And also coercing, that's another way for them to coerce their partner into continuing to use substances. All right, thank you all for participating. Okay, before I move on, Gabriella, did you have anything to add?
Yeah, what I'll add here, thank you, Jamie, is that with drug setting, we can talk with survivors about their relationship with substance use using drug setting. And what's really beautiful about it is that as we unpack it in this way, people start to identify different small changes they could make that would really improve their safety and their well-being. Because that any small change in one of these areas can have really big ripple effects in someone's experience of substance use and their safety related to substance use.
Thanks, Gabriella. So I'm gonna share my screen again. And I want to make sure that we have enough time for you all to ask questions. So we have about 10 more minutes. So I want to run through these last few slides pretty quickly before we ask for final questions. So we'll come back to the discussion question, but I just want to make sure that we do talk about what you can do as an advocate. Basically, you all are already doing a lot of the work that survivors experiencing substance use need. You know, as advocates, you are already talking about empowerment and voluntary services and supporting survivors' self-defined goals. You know, back to that, making sure that the survivor is involved in leading, driving their care, the services that they're receiving. Resource access and safety planning, you all do those things already. Harm reduction approach is very similar to the ways that you are already supporting your survivors. It involves working in partnership with the survivors to increase their physical and emotional safety. If their use of substances is putting them or others, like their children, at risk. This may involve steps people can take to reduce harm from the substances themselves, but also involve safety measures to reduce the harm from an abusive partner who engages in substance use coercion. Just a little bit about safety planning. You want me to run through this really quickly?
Sure, yeah, go for it. And let me just say, everyone start putting your questions in the chat because we're going to make sure to get to your questions once we're done in these next 2 slides.
Yes, thank you. So when safety planning, just like you would any other time, you know, just remain survivor defined and focus on their own priorities, what they need. You know, the survivors know best what they need and when they need it. So just listening to them and being there to support them through that safety planning. When we talk about integrated safety planning, so your substance use safety plan will go into that overall safety plan that you do with survivors. So it doesn't need to be something totally separate. It really is something that you're going to talk about in conjunction with one another. And so an example of individualized safety planning. So thinking about Valerie, the scenario we just used, and you know, her current partner was making all of her drinks, and so she had no idea how much she was drinking, what she was drinking. If you sat down with Valerie, maybe her recommendation for her individual safety plan would be that she volunteers to make the drinks. That way, not only does she know what and how much she's drinking, but she can even control how much she's drinking easier and water down what she's drinking or switch out alcohol for another beverage if she wanted to. But that's just another way that you can integrate the safety planning around that person's substance use into their overall safety plan, because that allows her to not just safely intake alcohol, but it also allows her to, or allows her to feel and be more safe in her relationship with her current partner. Okay. And then this last piece is just talking about collaborating with harm reduction organizations. Collaboration is key. And I know that a lot of you are doing that already, being involved in different coalitions and task forces and groups, you know, multidisciplinary teams. So a lot of what you're doing already will translate. And so what that might look like is cross-training with a substance use or harm reduction organization. If you are a DV org, because even though harm reduction organizations are very well versed in experience with what they do as far as approaching survivors with substance use disorder or substance use who are currently using substances, they might not be diagnosed. So, but they might not have the domestic violence knowledge and skills and resources. And so having that collaboration and that cross training just strengthens everyone's education and experience and ability to provide holistic services to survivors. Okay, and so that is the end of the presentation. So thank you all for sitting through that. And we're going to jump over to your questions. But one question that, if you can't think of anything that you might want to ask, I did want to ask the question, what are some concerns or challenges you're experiencing as an advocate or provider related to substance use in your current capacity? And so while everyone is typing out their questions, I'm just going to highlight some of these resources that you'll have access to with this slide deck. This is our contact information here at the center and ways that you can engage with the center, but we also have included several different resources, information that is free for your use and access on our website. And just for ease of access, I could put the links on all of these slides so that you can directly go to that particular resource. Okay. All right. So now time for questions. And I'll stop sharing.
Thank you, Jami. So there's a question here. If a client is highly intoxicated or under the influence at the time of meeting, it's really difficult for her to focus and retain information. How could you overcome this without being judgmental?
Yeah.
And so I'm happy to jump in. I know something that's really helpful, that's been really helpful when I've been working with folks, is getting a sense of whether there are certain times of the day that are better for them, right? And also talking with them around, you know, most of the time people are looking for like a happy medium when they're coming to see a provider. They're not trying to be very intoxicated. And so part of that is talking with them around, is there a better time of day for you? Is there a time where you are feeling the effects of your intoxication less, right? If you're able to openly talk about it. But sometimes people aren't there yet to be able to openly talk about it with us in our program. And then writing things down if it's safe for them to have written materials. So I've written things down like, this is your copy, or next time bring this, right? Or if they can't have written materials, calling later on if they can accept phone calls later and safely, and summarizing some of the follow-up steps.
Mhm. And then I see a question, and I'll come back to the comment. Yes, if you can hang on, I'll just answer this next question. What examples of service exchange are you suggesting with coordinating with harm reduction organizations? What would a DV agency exchange with a treatment center? Great question. So in Colorado, you all have a few harm reduction organizations. Let's see. I know that the public health
Amy, this is Brandy. I can jump in just for time's sake. I just want to let everyone know who's still on the call that we actually updated our technical assistance document on naloxone and Narcan, and we are going to be sending that out for you all. We are just waiting for the Spanish translation. So we will make sure that you all get that after the second webinar, which is next week, same time, same place. So I just wanted to make sure everybody knows that before we end today, that you all will get a copy of that. We'll send it out in multiple platforms, but especially for folks who are registered for this webinar, we want to make sure you all will get that, which will have a lot of resources in there. So I just want, hopefully that helps.
Perfect. Yes. Thank you for that. So what I would recommend is definitely connecting to those organizations and learning what services they provide, and maybe putting that somewhere into your intake packet or process as part of education for your survivors. Also, from working in a clinic setting, what I would recommend, and so what I recommended to the clinic that I most recently worked for was to have a DV advocate come in and do a training on domestic violence for the center staff, and as well as work on policy and procedure as far as responding to screening and responding to clients that self-reported being in a domestic violence situation. And then that way, and coming up with a response protocol, having someone that they could directly reach out to when referring clients for services if that client chose to engage in those services. So that's one way that you can collaborate with the treatment center, but they can also provide you with information on substances, and may even be able to provide you with naloxone, in-person naloxone administration, guidance on how to administrate Narcan or naloxone. Sorry about that. But yes, so those are ways that you can help each other. I hope that was helpful and made sense.
Yeah, and something I'll add to that is that there are DV programs that will offer support groups in harm reduction or in treatment settings, or offer like a healthy relationships group. And then through that, people start to gather more information about how their relationships, either currently or in the past, might be relationships that were coercive or abusive. And then that DV advocate is right there to offer that support and is that trusted resource to be the bridge back to the DV program.
This is Miranda. Thank you both so much. We really appreciate your time today. I am excited for folks to be a part of part 2. As mentioned, you'll have to re-register for that. It's on May 9th, but we'll be doing a more of a deeper dive into the difference between intoxication and overdose. We'll talk a little bit more of naloxone and Narcan, and really kind of dive into some of the questions that you all have. So if anything comes up, please bring those questions to our next May 9th. And we really appreciate everyone being here. Thank you so much.